It's a huge privilege to be asked to come back, as it were, to contribute to this symposium in honor of our friend Carlo. I was asked just to say a little bit about how I got to know Carlo and how he came to Cambridge before I just talk about this section. And as everybody knows now, by now, Carlo came to Cambridge in 1997 when we appointed him as one of our clinical lecturers. And we're very fortunate to have, at that time, 2 to 3 clinical lectures permanently all the time, and able to control exactly what they did and where they went. So that's been very useful and very productive. And one of the things I always did with any new clinical lecturer was to challenge that person to improve the undergraduate teaching course, which always needed improving. And Carlo took on that mantle with great enthusiasm. And as we've heard previously this afternoon, how well he's done in undergraduate teaching overall. And in fact, the course that Carlo organized at that time became a template for all the other specialties in the clinical school to follow. So that was a wonderful acknowledgement of his talent. And I was very pleased when we managed to create a new senior lecturer post, that Carlo obviously applied for that in competition with other people, and was appointed to that post. So I've had the pleasure and privilege of working with Carlo for more than 20 years, and clearly his loss has been a huge blow to us all in the department and beyond. Now, Ken has mentioned the Cambridge Birth Growth Study, and that did start initially. The raison d'etre for that initially was to study male reproductive development. And this was in collaboration, as Ken said, with an major EU grant that was coordinated mainly from Copenhagen. So the collaboration was with Copenhagen, and I had the grant to run it from Cambridge. So we cashed in, as it were, with the experience that Copenhagen had already had about monitoring the development of male infants throughout their early life. So obviously, since 50% of the births would not be male, it seemed a shame not to include those in any further studies. And as Ken has already said, the whole cohort of male and female came into the Cambridge Birth Growth Study, and a huge number of studies, which we just heard about, and many more, have come out of that remarkable resource. And it's great pleasure to see this resource 20 years later still thriving and developing further studies. So what I've done here now is take one aspect of that resource, which Carlo was involved with so much, and he became the principal investigator of this resource in due course. And he has been involved a lot with disorders and differences of sex development research in the department, but this particular aspect of endocrine disruptors is one I'm just highlighting for today's presentation. So the next slide is obviously just defining what is an endocrine disruptor. And this is a WHO-based definition. And basically it's a chemical or a hormone that disrupts the endocrine system and has adverse health effects in the intact organism, or even beyond that, in terms of the next progeny and subpopulation, which is of course a very important aspect to bear in mind. We have the next slide, please, Vicky. And so this is a classification that Carlo actually produced to give us an idea of what kind of chemicals we're talking about. There are about 80,000 of them, it's been estimated, that have these kind of effects, whether they're estrogen effects or anti-androgen effects. And they spread across a whole range of chemicals. Of course, pesticides we all know about. And there's been a huge movement now to try and get rid of all these pesticides that leach into the water supply and get into our water supply as well. The fungicides, And then, of course, plastics. I think nobody is now unaware of the huge burden this planet has that is drowned in plastic. And all these plastic leach chemicals which have these endocrine disrupting effects. Next slide, please. Now then, how can you study this? Well, of course, it's been studied in wildlife quite a bit. And this, I'm sure everybody's aware of turtles and how they reproduce and how they lay their eggs on land after having come out of the water. And in the case of turtles, the sex of the offspring is totally temperature dependent. And it's a very critical temperature. So the turtles are very clever in terms of when they decide to lay the eggs, to what the temperatures, as to whether they have male or female offspring. And in general, 28 degrees centigrade is the critical temperature for female eggs. 25 degrees centigrade is the critical temperature for male offspring. But you can now alter that balance by painting the shell of those eggs with various chemicals, including estrogens and BPA bisphenol A, which I'll talk about in a minute, and convert a male into a female offspring. So that's a pretty powerful effect that you can monitor in a very simple bioassay. But unfortunately, in humans, next slide, please. In humans, we don't have that kind of simple experiment. It's obviously not possible to do toxicology experiments in humans. Quite difficult to quantify the exposure to those 80,000 chemicals. Many of them are in low dose, so collectively there's a cocktail effect. And so we have to turn to immunology to study the effects that something may have in the environment. Next slide, please. And of course, in terms of vulnerability to these chemicals, it's the young, the fetus, and the growing child who are the most vulnerable and obviously highly relevant to those of us who are pediatricians. Next slide, please. And this slide we've seen in other formats already about the Cambridge Birth Growth Study. And again, this is a slide that Carlo produced at the beginning of the whole project. And it's still germane now, many years later, although there have been so many more things added to this slide now in terms of what's being measured. But this is the whole purpose of this is to have very detailed measurements in early infancy, having contained detailed questionnaire analysis of what the mothers were living and breathing during their pregnancy, and then following these infants up for 2 years. And of course now with CBGF1 and CBGF2, that follow-up is even longer. Next slide, please. So the first indication that there may be some male reproductive tract disorders that were perhaps environmental in onset came from the people in Denmark comparing their prevalence of cryptorganism, undescended testis, with a Finnish population almost adjacent in geographically. And you can see that in the Danish population shown by the purple, 9% of the male infants at birth had an undescended testis, whereas by 3 months of age, that prevalence had fallen to 2.4%, which is a well-recognized phenomenon. In contrast, in the Finnish population, those percentages were only 2% and 1% respectively. And shown in the square also, that they studied the volume of the testis by ultrasound, they measured hormone levels, they then follow these people up, obviously, and looked at sperm count and incidence of testis cancer. And that led to the concept of the so-called testis dysgenesis syndrome, where a quartet of undescended testis, hyperspadias, low sperm counts, and a high risk of testis cancer became known as that syndrome. So the next slide shows the work that Carlo did on the cohort within the Cambridge Birth Growth Study of what was the situation in the UK. And This shows that the prevalence of undescended testes in UK male infants born in the Cambridge area was nearly 7%. And a similar kind of study had been done by the John Radcliffe 25 years previously, and similar methodology, and the prevalence had doubled in that time. Again, Carlo found that the incidence fell to 2.9% by 3 months of age. But then, because of the Cambridge birth growth study, we were following these infants for 2 years. We were able to look at a phenomenon that hadn't really been described before, the so-called acquired or ascending testis syndrome. In other words, as you well know, newborn infants are fully examined at birth and hopefully checked correctly, and an undescended testis would not be missed. But sometimes these infants would be turning up again at 12 months of age where there was an undescended testis. And then why would that have happened? And it had been attributed initially to inadequate investigation and assessment at birth. That is not the case. There is actually a phenomenon of acquired or ascending testis syndrome. And you can see from that data, it had got back up almost to the same level as at birth. And this phenomenon was something that was a very original finding that Carlo found and quite unique. And obviously the surgeons in particular were interested in it as well. So that's the cryptorchism situation. Next slide, please. So we then went on later on to apply what was called the anogenital distance. Now, it's been known for many years that toxicologists working in animal studies, they can only sex a rodent at birth by this so-called anogenital distance. Vaginal opening, for example, has not occurred at birth in rodents. And the difference between males and females can be measured by taking this marker between the base of the scrotum in the male to the midpoint of the anus, and in the female from the posterior fourchette of the vagina to the midpoint of the anus. You can see in that diagram there, it's at least 2-to-1 ratio. So what would be the situation if this was done in the humans? And this was then added subsequently to the Cambridge birth growth study to find out, in terms of normal infants at birth, what were these measurements? Next slide, please. And the data is shown here, and this is work that Carlo had done with AJ Thankimoni in terms of the AGD measurements at birth right through to 2 years of age. And it's quite remarkable, this study, because you can imagine when an infant gets to about 12 months of age, it's not quite so easy to do this measurement with a struggling infant. So those nurses that Ken has been talking about have done a magnificent job to gather this data. And it's in a large number of infants, and you can see that there's a plateau occurring around about 12 months of age in terms of the increase in AGD, but the dimorphism is maintained between males and females. Next slide, please. And this phenomenon is actually present before birth, and this is on the left. Panel A is showing data in male and female fetuses, and you can see the dimorphism is occurring soon after the first trimester. And these measurements now can be done by ultrasound, and it's very accurate measurement. Again, in panel B, the Cambridge work, the Danish work, and that's been replicated now by many centers around the world. This phenomenon is present, and again in adult life. Next slide, please. So how can you apply this now in terms of looking at the environment to see what may be causing it? Well, the first thing to do, obviously, was to go back, once we had this technique, to go back to the infants with cryptorchism, and also a number of infants with hyperspadias. And you can see on this slide that compared to the healthy boys on the first panel there, boys with cryptorchism have a significant reduction in the AGD measurement. And also the length of the penis was also reduced. And similarly, even more reduction in hypospadis, a more severe abnormality of the genitalia. In hypospadis, again, there's a significant reduction in the AGD compared to normals, as it is in penile length. So the next step was to see whether we could badge this now with any measurements taken of endocrine disruptors in the samples that have been collected over the years in the Cambridge Birth Growth Study. Next slide, please. And this is work that has just been published now. So sadly, this is being published posthumously in terms of Carlo's contribution, but it's a major contribution to the field. An incredibly challenging study, this. And this is done by Ben Fisher, who is a PhD and an academic clinical fellow in the department, and with Carlo. And what is shown here in this scatter plot is the measurement of various chemicals that were measured in the maternal blood samples collected during pregnancy. And this is a huge study undertaken by the chemistry laboratory in Copenhagen by tandem mass spectrometry, measuring 16 phthalates, 9 phenols, and 6 parabens chemicals. And what is shown on the vertical axis on the left is one of the phthalates. And there is a relationship, significant relationship between lower levels of lower measurements of AGD and increased levels of these chemicals. And the OR there, the odds ratio, 2.9, is the association between the AGD and infants with cryptorchidism. In other words, those boys with cryptorchidism had significantly higher levels of bisphenol A, the chemical that you can apply to the egg of a turtle to change it from a male to a female. This is the chemical that we identified in the maternal serum samples that are associated with the offspring of those mothers who had boys with cryptorchidism. So this is it's quite a powerful observation, and this publication is now a key publication in the field to show the relationship between the environment and male reproductive abnormalities at birth. Next slide, please. So what has happened now, because so many centers have been developing these techniques, some of them do the measurements slightly differently, a consortium has now been established, and AJ Thankemoni is part of this consortium. Centers in Denmark, 2 centers in Denmark, the Cambridge Center in the UK, and there's a large center also in New York. All have pooled their resources to produce, and this has been published recently, have pooled their resources to get if you like, a standard centile charts for this measurement. And this, of course, now can be used in epidemiological studies by other people working in the field. Very recently, there's a major publication come out about all-cause mortality is increased with increasing bisphenol A exposure. And this is from the NANES resource, which is a major epidemiological resource in the US, showing that cardiovascular disease and cancer is increased mortality in relation to exposure. And the fact is that 90% of all individuals have bisphenol A in their bodies, and the level of that exposure seems to be now associated with all-cause mortality. And thank goodness, something is at last happening in terms of having legislation both in the States and in the European Union to restrict the use of all these chemicals and plastics, pesticides, various consumer products, perfumes, everything that we're exposed to in our daily lives. There is now legislation. It's impossible to remove it, but in terms of the precautionary principle to try and reduce the exposure. And now, my last slide, please. It is now actually evident in practice. And so this is on the shelf of a supermarket that I was in recently. And here we have now born plastic free for these wipes for little babies, having their nappies changed. and these will be BPA free. So at least something is tangible is beginning to happen in terms of improving the environment for the next generation coming through. Thank you for your attention.